Hi, my name is Donna Edwards, and today we are going to be discussing motivation for change. Motivation to initiate and persist in change fluctuates over time, regardless of the person's stages of readiness. From the client's perspective, a decision is just the beginning of change. The key messages here are: motivation is the key to substance use behavior change. Counselor use of empathy, not authority and power, is essential to enhancing client motivation to change. The trans-theoretical model, TTM, of stage of change, SOC, approach is a useful overarching framework that can help you tailor specific counseling strategies to the different stages. Let's take a look at the trans-theoretical model stages of changes. In the pre-contemplation stage, there is a no. In the contemplation stage, there's a maybe. In the pre-contemplation stage, you are going to prepare and plan to possibly make some changes. And then there's the action stage. You are going to change. And then the maintenance, you're going to keep going. You're going to maintain your level of change. Why do people change? How is motivation linked to substance use behavior change? How can you help clients enhance their motivation to engage in substance use disorder treatment and initiate recovery? These questions will be answered in this presentation. In the past 3 decades, the addiction treatment field has focused on discovering and applying science-informed practices that help people with SUDs enhance their motivation to stop or reduce alcohol, drug, and nicotine use. Recovery support helps prevent or lessen the social, mental, and health problems that result from a reoccurrence of substance use or a relapse to previous levels of substance misuse. We will examine motivational enhancement and substance use behavior change using 2 scientific informed approaches. The first one that we will discuss is motivational interviewing, MI, which is a respectful counseling style that focuses on helping clients resolve ambivalence about enhanced motivation to change health risk behaviors, including substance misuse. The TTM of SOC, which provides an overarching framework for motivational counseling approaches throughout all phases of addiction treatment. Motivation and behavior change. Motivation is a critical element of behavior change, so you must be motivated to change. Acknowledge motivation as a multi-dimensional fluid state during which people make difficult changes to health risk behaviors like substance misuse. The nature of motivation. Motivation is a key to substance use behavior change. One framework for understanding motivation and how it relates to behavior change is the self-determination theory, SDT. The SDT suggests that people inherently want to engage in activities to meet their need for autonomy, competency, example given, self-sufficiency, and relatedness. Intrinsic motivation, example given, the desires, needs, values, and goals. Extrinsic motivation, example given, social influences, external rewards, and consequences. Here you will see a cycle of the stages of change, starting with the pre-contemplation that does not recognize the need for change or is not actively considering to change. Contemplation, recognizing that there is a problem and is considering to change. The pre-contemplation action stage is it has initiated the change. The maintenance is adjusting to change and is practicing new skills and behaviors to sustain change. Then there is the levels that there's the ones that relapse and they leave treatment, and then the cycle can begin again. Here we look at the intrinsic goals and the extrinsic goals. Intrinsic goals, the self-worth, knowledge, growth, passion, dedication, fun, and purpose. Extrinsic goals, examples, deadlines, social status, money, prizes, winning, failure, and perks. MI is a counseling approach that is consistent with STD and emphasizes enhancing internal motivation to change. In the STD framework, providing a supportive relational context that promotes clients' autonomy and competence enhances the intrinsic motivation and helps clients internalize extrinsic motivation rewards and supports the behavior to change. Contingency management is a counseling strategy that can reinforce extrinsic motivation. It uses external motivators and reinforces, example giving, expectation of a reward or a negative consequence to enhance behavior change. Motivation helps people resolve their ambivalence about making difficult lifestyle changes. Helping clients strengthen their own motivation increases the likelihood that they will commit to a specific behavioral change plan. Motivation and positive addiction treatment outcomes. Motivation and readiness to change are consistently associated with increased help-seeking treatment adherence and completion and positive SUD treatment outcomes. Motivation is multidimensional. Motivation includes clients' internal desires, needs, and values. It also includes external pressures, demands, and reinforces positive and negative that influence clients and their perceptions about the risk and benefits of engaging in substance use behaviors. Two components of motivation predict good treatment outcomes. The importance clients associated with changes. Their confidence in their ability to make changes. Let's take a look at the models of addiction. The model for moral legal. The underlying assumptions for moral legal is that addiction is a set of behaviors that violates religious, moral, or legal codes. The treatment approaches are abstinence and use of willpower, external control through hospitalization or incarceration. The psychological model underlying assumptions are addiction results from deficits in learning, emotional dysfunction, or psychopathology. The treatment approaches for this is cognitive, behavioral, psychoanalytic, or psychodynamic, or psychotherapeutic. Let's look at the model for sociocultural. The underlying assumptions are addiction results from socialization and social cultural factors. Contributing factors include socioeconomic status, cultural and ethic beliefs, availability of substances, laws and penalties regarding regulating substance use, norms and rules of families and other social groups, prenatal and peer expectations, modeling of acceptable behaviors, and the presence or abstinence of reinforcers. The treatment approaches for this is focused on building new social and family relationships, developing social competency and skills, and working within the client's culture. The underlying assumptions for the spiritual model are addiction is a spiritual disease. Recovery is predicated on a recognition of the limitations of the self and desire to achieve health through a connection that which transcends the individual. The treatment approaches are integrating 12-step recovery principles or other culturally based spiritual practices. Example given, American Indian Well-Briti principles into addiction treatment, linking clients to 12-step faith and spiritual-based recovery and other support groups. The underlying assumptions for the medical model is addiction is a chronic progressive disease. Genetic predisposition and neurochemical brain changes are primary etiological factors. The treatment approaches are medical and behavioral interventions, including pharmacotherapy, education, and behavioral change, advice, and monitoring. The underlying assumptions for the integrated treatment model is that addiction is a chronic disease that is best treated by collaborative and comprehensive approaches that address biopsychological and spiritual components. The treatment approaches are integrated treatment with a recovery focus across the treatment settings. Earlier perspectives. Although the field is evolving towards a more comprehensive understanding of SUD, earlier views of addiction still persist in parts of the U.S. addiction treatment system. For example, the psychological model of addiction treatment gave rise, in part, to the idea of an addictive personality, and that psychological defense, example given, denial, need to be confronted. An addictive personality leads to SUDs. Although it is commonly believed that people with SUDs possess similar personality traits that make treatment difficult, not distinctive personality traits have been found to predict. Rationalization and denial are characteristics of addiction. Another leftover from earlier psychological perspectives on addiction is that people with SUDs have strong psychological defenses, such as denial and rationalization, which lead to changing behaviors like evasiveness, manipulation, and resistance. Resistance is a characteristic of unmotivated clients in addiction treatment. When clients are labeled as manipulative or resistant, given no voice in selecting treatment goals, or directed authoritatively to do or not to do something, the result is a predictable response of resistance or reactivity to the counselor's directives. Viewing resistance along with rationalization and denial as characteristic of addiction and making efforts to weaken these defenses actually strengthens them. This paradox seemed to confirm the idea that resistance and denial were essential components of addiction and traits of the client. Confrontation and psychological defenses and substance misuse behaviors is an effective counseling approach. Historically, the idea that resistance and denial are characteristic of addiction led to the use of confrontation as a way to aggressively break down these defenses. However, adversarial confrontation is one of the least effective methods for helping clients change substance use behaviors, can paradoxically reduce motivation for beneficial change, and often contributes to poor outcomes. Yet, there is a constructive type of confrontation. This kind of confrontation must be done within the context of a trusting and respectful relationship and is developed in a supportive way that also elicits hope for change. A new look at motivation, a new perspective. As the addiction treatment field has matured, it has tried to integrate conflicting theories and approaches and to incorporate research findings into the comprehensive model. The following sections address recent change in the addiction treatment, with important implications for applying motivational methods. Focus on the client's strengths. Historically, the treatment field has focused on the deficits and the limitations of the client. Today, greater emphasis is placed on identifying, enhancing, and using client strengths, abilities, and competencies. This trend parallels the principles of motivational counseling, which affirm clients, emphasize personal autonomy, support, and strengthen self-efficacy, and reinforce that change is possible. The responsibility for recovery rests with the clients, and the judgmental tone, which is a remnant of the moral model of addiction, is eliminated. Individualized and person-centered treatment. In the past, clients frequently received standardized treatment, no matter what their problems or SUD severity. Today, treatment is increasingly based on the client's individual needs, which are carefully and comprehensively assessed at intake. Positive outcomes such as higher levels of engagement and psychological treatments, decreased alcohol use, and improved quality of life are associated with person-centered care and a focus on individualized treatment. In this perspective, clients have choices about desirable, sustainable treatment options. They are not prescribed treatment. Motivational approaches emphasize choice by eliciting personal goals from clients and evolving them in selecting the type of treatment needed or desired from a menu of options. A shift away from labeling. Historically, a diagnosis or disease defined the client and became a dehumanizing attribute of the individual. Today, individuals with asthma or a psychosis are seldom referred to as the asthmatic or the psychotic. Similarly, in addiction treatment arena, there is a trend to avoid labeling clients with SUDs as addicts or alcoholics. Using a motivational style will help you avoid labeling clients, especially those who may not agree with the diagnosis or do not see a particular behavior as problematic. Person-first language. Example given, a person with an SUD is the new standard. To reduce the stigma, it helps clients disentangle addiction from identity and eliminates the judgmental tone left over from the moral model of addiction. Therapeutic partnerships for change. In the past, especially in the medical model, the client passively received treatment. Today, treatment usually entails a partnership in which you and the client agree on treatment goals and together develop strategies to meet those goals. The client is seen as an active participant in treatment planning. Using motivational strategies fosters a therapeutic alliance with the client and elicits goals and change strategies from the client. The client has ultimate responsibility for making changes. It is more productive to use of empathy, not authority or power. Historically, addiction treatment providers were placed in the position of an authority with the power to recommend client termination for rule infractions, penalties for positive urine drug screens, or promotion to a higher phase of treatment for successfully following direction. Research now demonstrates that counselors who operate from a more authority-driven way of relating to clients, such as confronting or being overly directive are less effective than counselors who employ empathy, understanding, and support with clients. This style of counseling is a particularly poor match for clients who are angry or reactive to counselors' direction. Positive treatment outcomes, including decreased substance use, abstinence, and increased treatment retention, are associated with high levels of counselor empathy, good interpersonal skills, and strong therapeutic alliance. Integration of addiction, behavioral health, and healthcare services. Historically, the SUD treatment system was isolated from the mainstream healthcare by different funding streams, health insurance restrictions, and lack of awareness and training among healthcare providers on recognizing, screening, assessing, and treating addiction as a chronic illness. Today, a concentrated effort is underway to integrate addiction treatment with other behavioral health and primary care services to build a comprehensive healthcare delivery system. Natural change. There are two kinds of natural change. Natural changes relate to substance use can go in either direction. In response to an impending divorce, for example, one individual may begin to drink heavily, whereas another may reduce or stop using alcohol. Recognizing the process involved in natural recovery and self-directed change illustrates how changes related to substance use behaviors can be precipitated and stimulated by enhancing motivation. Here are some examples of natural changes. Common natural changes: going to college, getting married, getting divorced, changing jobs, joining the army, taking a vacation, moving, buying a home, having a baby, retiring. Natural changes in substance use: stop drinking after an automobile accident, reducing alcohol use after college, stopping substance use before pregnancy, increasing alcohol use during stressful periods, decreasing cigarette use after a price increase, quitting cannabis use before looking for employment, refraining from drinking with some friends, reducing consumption following physical advice. Here again we look at the 5 stages. We start with the pre-contemplation, no intention on changing behavior. The contemplation, aware of a problem exists but no commitment to action. The pre-contemplation, intent to taking action to address the problem. The action is the active motivation of modification of behavior. Maintenance, sustained changes, new behavior replaces old. Relapse, fall back into the old patterns of behavioral. It's an upward spiral. Learn from each relapse. You want to pick the new life or the old life? With pre-contemplation, people use substance, are not considering change, and do not intend to change in the foreseeable future. They may be partly or completely unaware that a problem exists, that they have to make changes, and that they may need help to change. Alternatively, there may be unwilling or too discouraged to change their behavior. Individuals in this stage often are not convinced that their pattern of use is problematic. In the contemplation stage, as these individuals become aware that a problem exists, they begin to perceive that there may be cause for concern and reasons to change. Typically, they are ambivalent, simultaneously seeing reasons to change and reasons not to change. Individuals in this stage are still using substances, but they are considering the possibility of stopping or cutting back in the near future. At this point, they may seek relevant information, reevaluate their substance use behavior, or seek help to support the possibility of changing. They typically weigh the positive and negative aspects of making a change change. It is not uncommon for individuals to remain in this stage for an extended period, often for years, vacillating between wanting and not wanting to change. In the preparation, when individuals perceive that the envisioned advantages of change and adverse consequences of substance use outweighs the benefits of maintaining the status quo, the decisional balance tips in favor of change. Once initiated of change occurs, individuals enter the pre-preparation stage and strengthen their commitment. Preparation entails more specific planning for change, such as making choices about whether treatment is needed and if so, what kind. Preparation also entails examining clients' self-efficacy or confidence of their ability to change. Individuals in the preparation stage are still using substances, but typically they intend to stop using very soon. They may already be making small changes like cutting down on their substance use. They begin to set goals for themselves and make commitments to stop using, even telling close associates or significant others about their plans. In the action stage, here individuals choose a strategy for change and begin to pursue it. Clients are actively engaged in changing substance use behaviors. They are making lifestyle changes and may face challenging situations. Example given: temptations to use, physiological effects of withdrawal. Clients may begin to evaluate their self-image as they move from substance misuse to non-use or safe use. Clients are committed to the change process and are willing to follow suggested change strategies. In the maintenance stage, this is the stage that entails efforts to sustain gains made during the action stage and to prevent reoccurrence. Extra precautions may be necessary to keep from reverting to health risk behaviors. Individuals learn to identify situations that may trigger and return to substance use and develop coping skills to manage such situations. During maintenance, clients are building a new lifestyle that no longer includes the old substance use behaviors. Relapse or reoccurrence of substance misuse is a common part of the process as people cycle through the different stages. Although clients might return to substance misuse during any of the stages, relapse is most often discussed as a setback during the maintenance stage. In this model, reoccurrence is viewed as a normal, not a pathological event because many clients cycle through different stages several times before achieving stable change. Reoccurrence is not considered a failure, but rather a learning opportunity. Remember that each time a client has a setback, they are learning from the experience and applying whatever skills or knowledge they have gained to move forward in the process with greater understanding and awareness. In conclusion, recent understanding of the key role motivation plays in addiction treatment has led to the development of clinical interventions to increase client motivation to change their substance use behaviors. In this treatment approach, motivation for change is seen as a dynamic state that you can help the client enhance. Motivation is what propels people with SUDs to make changes in their lives. It guides clients through several stages of change that are typical of people thinking about initiating and maintaining new behaviors.